Welcome everyone to our latest Queen Elizabeth Scholarship webinar coming to you from the McMaster Health Forum here at McMaster University. We have a unique presentation today and we'll get to the uniqueness of it in just a second. Here's a quick agenda. I'll tell you a little bit about the McMaster Health Forum, a little bit about the Queen Elizabeth Scholarship Program, and then I'll turn it over to our presenters, of which we have 3 today. It's the first time we've had 3 presenters for one of our webinars. They all traveled together to Malaysia, and they'll tell you all about their fun and exciting experiences. What's also unique is that they are all in 3 different places. So we have one person here with me at McMaster, we have one in Ottawa, we have one in Toronto. So the McMaster Health Forum is the leading hub for improving health outcomes through collective problem solving, harness information, convene stakeholders, and prepare action-oriented leaders, and act as an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between the Rita Hall Foundation, Community Foundations of Canada, Universities Canada, and individual Canadian universities. The purpose is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The Queen Elizabeth Scholarship Program is offered by the McMaster Health Forum is called Strengthening Health Systems. Our scholars contribute to strengthening health systems and become part of our large and growing network of health system leaders. We've had 2 cohorts of scholars so far. On the screen now is our first cohort who primarily went away or visited us in 2016. Here we see a list of the students from our second cohort who primarily went away in the winter and summer of 2017. And our current presenters for today come from this cohort. So of our 3 presenters, the first one I'll introduce you to is Seana. She's currently a Bachelor of Health Sciences undergraduate student here at McMaster. She developed an interest in how research can impact healthcare practice and policy. And one of the aims of her internship was to strengthen her holistic understanding of global health and understand the systems that perpetuate global health inequality or inequity. And she's just finishing her 4th year honors degree. Our second presenter is Elysia, who at the time of her internship was also a Bachelor of Health Sciences undergraduate student here at McMaster. She has a keen interest in patient involvement in policy and learning how to incorporate research evidence into decision-making. One of the aims of her internship was to further her understanding of international health systems and how research evidence can influence policy and system-level interventions. Elysia is currently in the MD program at the University of Ottawa. And our third presenter today is Lucshman, who also was, at the time of his internship, a BHSC undergraduate student here at McMaster. He has an interest in understanding the social determinants that affect the physical and mental health of individuals. One of the aims of his internship was to understand the tools and methodologies used in health systems research and the strategies that can help build health systems research capacity in low and middle income countries. Lucshman is currently in Toronto in the MD program at the University of Toronto. So with all that said, 3 presenters to go. I'll turn it over to Seana first, and enjoy.
So as James mentioned, today's presentation will be on our internship in the Institute for Health Systems Research in Malaysia. So an overview of our presentation, we'll begin by giving a background of Malaysia's healthcare system and its similarities to the Canadian healthcare system. We'll then be giving an overview of the Institute for Health Systems Research, which is where we spent our 3 months. Specifically, we were in the Health Outcomes Research Division. We'll also be presenting the 3 deliverables that we worked on while in Malaysia, and those 3 projects that we worked on simultaneously were an evidence brief, a healthcare demand survey, and a deliberative dialogue assessment tool. We'll be concluding our presentation with a summary of the conferences and workshops that we also got to attend while in Malaysia, which were very interesting. So this is where we spent our internship. It was in the city of Shah Alam in West Malaysia and the Institute for Health Systems Research. This is a picture of our office colleagues that we got to know very well over the 3 months. I'm not in this picture, I'm taking the photo, but you can see Elysia and Lush on the right-hand side. And this is a picture of all of our colleagues in the Institute, not only in the Health Outcomes Research Division.
So just to begin with some context, we want to give you an overview of Malaysia's healthcare system. So Malaysia's healthcare system is a 2-tiered system which consists of a tax-funded and government-run public sector and a private sector. So the public sector is run by the Ministry of Health, which is where Lucshman, Seana, and I worked, and it encompasses hospitals, clinics, doctors, dentists, medical assistants, and nurse practitioners. And it is tax-funded, so everyone has universal coverage for these services in public facilities. The other tier of the Malaysian healthcare system is the private tier, and it encompasses essentially everything that the public does, in addition to traditional and complementary medicine, as well as pharmacy and pathology labs. And mainly the people who access private healthcare, the people who can afford it, and also the people who live in urban areas, because that's where most of these private centers are located. So under the Ministry of Health, we also have the National Institutes of Health, which are the research institutes in the Ministry of Health. And so highlighted here, we see the Health Systems Research Institute, which is under the National Institutes of Health, which is where we work. So just to give you a little overview of the Institute of Health Systems Research and what their goals are. So we have three main goals here. They provide scientific evidence to policymakers and health managers to enable them to make evidence-based decisions. They play a role in strengthening knowledge translation, and they play a part at many different levels in facilitating decision-making processes that occur within the health system. So really IHSR has a lot on their plate because they kind of do two things. So they play a role in facilitating decision-making and ensuring evidence is incorporated into decision-making and knowledge translation, in addition to conducting their own primary research and testing out the effectiveness of different interventions to provide evidence to make policy decisions on. So they really do have a lot on their plate.
So within IHSR, there's 8 different divisions. The one that we worked on or worked in was the Health Outcomes Research Division. So here in this picture, you can see a number of colleagues that we worked with. Researchers within the Health Outcomes Research Division really did come from a lot of different backgrounds. A good number of our colleagues were medical doctors who did clinical work for a number of years before ultimately transitioning into research. Others held backgrounds in pharmacy and nursing as well. So overall, the Health Outcomes Research Division focuses on assessing the benefits for resources invested, the types of strategies to improve research outcomes, and how to create a better environment to foster better health systems outcomes. And IHSR defines systems outcomes as outcome measures influenced by the different policy, programs, services, or other activities that really represent change at a health systems level. And so the Health Outcome Research Division tries to assess how the Ministry of Health's resources can best be used to benefit the health system while also holding the ministry accountable for the resource expenditure, often conducting process and outcome evaluations on new changes and interventions that are introduced into the health system. And the Health Outcome Research Division is also in a really unique position to assess the interaction between institutions with different policy, professional, and commercial authority, which includes private insurers and drug companies, and how their interaction really affects the health system. So again, looking into the 4 broad domains that the Health Outcome Research Division works on, one is health outcome measures, which include, is the ministry getting value for their investment in resources, and is patient experience improving, and what are the public health outcomes of these investment in resources. They also investigate the population-based and clinical-based programs and interventions that are administered, and how these public programs can be financed and administered in a way so that there's an appropriate population-level benefit. And the division also follows up on these programs to see if these benefits are sustained. They also look into methods for health outcome measurement, and this includes investigating measures to capture population-level health information through the use of questionnaires and surveys. And as you'll see in one of our projects, we helped out with this aspect of their work while working on the healthcare demand survey. And finally, the Health Outcome Research Division really tries to foster research skills in conducting this type of research. During our time with the division, they trained a number of scholars, most of which who were medical students, who would assist on different projects and learn research skills relevant to the field.
So as was mentioned, a compilation of our deliverables include an evidence brief, a healthcare demand survey, and a deliberative dialogue assessment tool, which we worked on simultaneously for the 3 months while we were in Malaysia.
So in terms, the first project we worked on was the evidence brief. IHSR, as mentioned before, does conduct a lot of primary research into the Malaysian healthcare system. And because of this, the only formal documents they really produced were something called research highlights, which were really focused on primary research. And so they didn't really have a background in conducting evidence briefs, which ultimately aimed to bring together high-quality, synthesized, and locally applicable research evidence to evaluate a problem and potential policy options. So essentially, our task was to operationalize an evidence brief synthesis process within the organization based on the model from the McMaster Health Forum. And so to do this, we decided to focus in on a locally relevant issue within the Malaysian context, which was that of needlestick injuries. And so needlestick injuries are really a common occupational hazard that a healthcare worker in Malaysia is exposed to. The Occupational Health Unit in the Ministry of Health within Malaysia reported an incidence rate of 4.7 NSIs per 1,000 healthcare workers in 2005. And despite extensive surveillance on the issue, these rates didn't really go down. And so the organization and ourselves felt that this was a good issue to build an evidence brief around. So our task, as mentioned before, was to direct the Institute on how to formulate an evidence brief for needlestick injuries. In terms of challenges, one issue that really surprised us was that individual researchers within the Institute had difficulties accessing articles from databases. And this served as an initial barrier to really bringing together literature relevant to the issue. Another challenge was really a lack of evidence that could be applied to the Malaysian context. Despite extensive monitoring of the issue, there were really no qualitative studies or systematic reviews conducted on the issue within Malaysia. And this same sort of idea applied when assessing policy options to address the issue. Many systematic reviews looked at interventions in countries other than those in Southeast Asia. And so sometimes we had to rely on lower quality evidence to really frame the problem and explore policy options. This included evidence like single studies that were conducted at specific hospital sites within Malaysia instead of synthesized research. And so some lessons learned was that access to literature is really important and something that I think we took for granted as students of McMaster University. Another really important lesson was that local applicability of evidence is very important, and it's something that we found the researchers and stakeholders are really looking for when you bring to them an evidence brief for any kind of document. It's how does this apply to where we are now, which is Malaysia. And so the outcome of the evidence brief, ultimately we brought the group together and we formulated multiple search strings related to the problem of needlestick injuries in Malaysia. We came up with a comprehensive list of databases that we could use the search strings in. The team compiled and collected evidence from these articles and synthesized it so we could get a better understanding of the problem as it relates to Malaysia. We repeated this process to look for potential policy options, and in doing this, we think the team really gained an understanding of the steps involved in collecting and synthesizing information for an evidence brief. And so based on the evidence we collected, which included systematic reviews and single studies that looked at the issue in Malaysia, as well as a few ground perspectives from nurses and physicians involved in the issue, we identified a few causes of NSI in Malaysia. One was instrument defects. So many reports highlighted that recapping and other complex manipulations of needles were a significant burden of needlestick injury in Malaysia. Another was poor supervision and untrained staff. So there really was a lack of leadership within hospitals to ensure that the staff were trained and that there were robust reporting mechanisms for when an injury occurred. There was also poor compliance of providers to the standard operating procedure. Despite workers having knowledge of the procedure, a lot of them didn't really follow it. In fact, the recapping needles was a procedure that was prohibited, but 75% still did that procedure. And that leads into the next point, which was that the healthcare worker attitudes and workloads also represented a burden of needlestick injury. And it reflects an issue that perhaps universal precautions weren't properly ingrained within the safety culture of the MOH hospitals. And so in terms of policy options identified, we were looking on policy options on the basis of the availability of the evidence as well as its applicability to Malaysia. And we also examined policy options based on what additional changes we felt were needed to accompany an option. And so we tried to answer the questions of, what were the impacts of each policy option, what were the local costs of each option, what adaptations might need to be made to make the implementation more feasible in Malaysia. And we came up with a number of policy options. One was increasing the layers of standard gloves, which proved to be a really cost-effective policy option. Another was to train safe injection procedures and the proper use and disposal of sharps. Another was to train staff in appropriate surgical techniques to mitigate the risk of a needlestick injury in those settings. We also came across a number of occupational healthcare management frameworks that could be incorporated within hospitals to improve reporting mechanisms and supervision of staff. And we found a number of synthesized reviews looking at a combination of training and safety engineered devices to improve those NSI rates.
In addition to working on the evidence brief, we also had the opportunity to work on the Healthcare Demand Survey, which is a national survey that's used to assess healthcare demand, utilization, and population perceptions about healthcare, the healthcare system in Malaysia, to inform reform in the healthcare system. So it was administered to the population in 1986, 96, 2006, 2011, and 2015, and the next survey is going out in 2018. And the reason that we were working on it is because we wanted to uncover new questions and refine the survey to get a greater scope of information, and to also ask questions that can reflect current changes that occurred in the healthcare needs of the population. So this consisted of delving into the literature to find national health surveys of different countries, and basically what we did was compare these questions from other countries to the questions that were in the Malaysian healthcare demand survey. And through this process, we could identify questions that we should add and potentially take out and modify in order to get a greater scope of the information from the population, and also add certain categories. So some areas of interest that they wanted to add into the survey were questions focused on patient-centered care, questions centered on the socioeconomic status of the population, and also questions that captured discrimination within the healthcare system. And so those are some of the areas of focus when we were doing our literature searches. Some challenges that we encountered in this process were adjusting the questions to the cultural differences in Malaysia. And some lessons learned from this process were that every country will have some baseline questions that will apply to everyone, but each country and culture also has specific questions that need to be adapted to the context of the country. So really what we did was we met regularly with the researchers at the Institute of Health System Research to discuss which questions should we put, and to discuss the specific wordings of certain questions for the refinement of the healthcare demand survey.
So the third project that we worked on were deliberative dialogues. So we worked on compiling a deliberative dialogue assessment tool with survey questions. So in Malaysia, government research institutes host deliberative dialogues for key stakeholders. It's important to note that their deliberative dialogues do differ from McMaster Health Forum's definition of deliberative dialogues. So their dialogues attempt to discuss the problem, policy option, and implementation considerations of an issue, and these are usually accompanied by primary research that is conducted by the Institute. So IHSR sought to evaluate the current state of their deliberative dialogues from the perspective of their participants. So as I mentioned, our task was to evaluate the current status of IHSR stakeholder dialogues and provide an evaluation tool to assess how to improve upon them in the future. Some challenges were how to word the questions. So we did look at the McMaster framework for stakeholder dialogues, and we found that there were some components present at the McMaster Health Forum that were not yet present in the Institute for Health Systems Research. For example, having a facilitator. So we had to discuss and deliberate whether to include questions that looked at whether components were present or absent. For example, was there a facilitator present? Or how useful the components were. So how useful did you find the facilitator? And after feedback from our colleagues in the Institute, we got that even if some components were not yet present in their stakeholder dialogues, we should still word the questions in terms of how useful the components were, because it gave them a goal and something to search for and to work towards, that their deliberative dialogues could be improved. Some lessons learned was that culture has a big impact on how to give and receive feedback. So in a lot of the stakeholder dialogues, there's a question and answer period, and there's also a period to receive feedback. And a lot of times, people were reluctant to give feedback, and when asked why, the response we got was that it's just a cultural thing. So to circumvent this, we ended up doing one-on-one interviews with a lot of our colleagues in IHSR in case they were reluctant to share their opinions because of higher authority that may be around. The outcome was that we administered this questionnaire at 2 stakeholder dialogues and identified strengths and weaknesses of the sessions. So the first stakeholder dialogue was a nursing stakeholder dialogue, and the second one was a dialogue that looked at childhood obesity and diabetes rates in the country. This is a timeline of our tool. So in May, we researched models for evaluating deliberative dialogues and also relied on the McMaster Health Forum framework, and then we field tested the tool at the nursing deliberative dialogue. In June, based on feedback, we ended up revising the tool and changing the wording of the questions, and then field tested the tool again at the second deliberative dialogue on childhood obesity and diabetes rates, and that was in July. And then in August, we finalized the tool based on the overall feedback just in time before we departed to come back to Canada. So this is a presentation of us giving an overview of deliberative dialogues to our colleagues in IHSR. So what coupled these 3 projects that we worked on were weekly or bi-weekly presentations that we gave to our colleagues in the Institute. And these presentations summarized the work we were doing and also gave them the baseline for why we were doing what we were doing. So for example, our colleagues knew that we were working on a deliberative dialogue assessment tool, and some of our leaders within the Institute encouraged us to present what deliberative dialogues were to our colleagues, for those who weren't aware. So we would share what deliberative dialogues were, what was contained within them, some challenges, how to synthesize research, etc. So this is an example of a checklist that relied upon the McMaster Health Forum framework for deliberative dialogues that we used to adapt to the Malaysian context. For example, we looked at, does IHSR currently have facilitators? And what we found was that in several of their stakeholder dialogues, they do not have facilitators present, and if they did, it was not a neutral party. It was somebody in power who had influence. And so this was something that we discussed with the Institute, and we suggested to find facilitators that were neutral parties to have present at their dialogues in order to improve them. We looked at, does it follow Chatham House Rule? So Chatham House Rule essentially means that participants can use information in a session, but cannot attribute comments to individuals. So there's an element of anonymity there. And we shared this definition with our colleagues within the Institute so that they could have a better understanding of how to improve their dialogues. Based on feedback from the nursing stakeholder dialogue, we got that the wording was too complex. They also wanted to see more questions about the use of research evidence within our survey, and they thought that the evaluation scale was very subjective. So we ended up using a Likert scale that went from 1 to 5, and the wording was, for example, I found this strongly useful or somewhat useful, and they found that wording to be very subjective, and so we worked with them to use terms and words that they could interpret better. Based off of feedback from the childhood obesity and diabetes deliberative dialogue and the nursing stakeholder dialogue, we got that IHSR should host deliberative dialogues that are more focused. They also thought that academics should be present at these deliberative dialogues, and they wanted to see representation from individuals working at the ground level to discuss their struggles and challenges. They also thought that reference materials should be provided as resources before the dialogue session. So at the McMaster Health Forum, evidence briefs are pre-circulated before a deliberative dialogue is held, and this was suggested that IHSR should adopt the same component because all the members who come to the deliberative dialogues could have a better understanding of what the research is, any background information before discussing at the table with stakeholders. Some features that are currently employed at IHSR that participants would like to see practiced and continued are the question and answer period and also the presence of main stakeholders. So as an overview, based off of surveying this deliberative dialogue assessment tool that we developed, the strengths of the current deliberative dialogues at IHSR are that they adequately discuss the problem and its causes with appropriate local content, and the evidence presented at the meetings are usually likely to directly inform policy making. Some areas of improvement are that there is not a fair representation of individuals involved in the issue. So for example, at the nursing stakeholder dialogue, several of the participants were nurses and there were no pharmacists or physicians. So they wanted to see more representation. And there's also a lack of synthesized research evidence presented at these meetings. It's mostly local primary research. So as Lush mentioned, they don't have that much access to databases such as PubMed, JSTOR, ScienceDirect, and this can prevent their access to synthesized research evidence, which could help the stakeholder dialogues and the research that goes before that.
So now we'll be talking a little bit more about the sort of conferences and workshops that we attended while we were at IHSR. So coming into IHSR, they really took the time to find out what we wanted to learn, how they could foster a sort of bilateral exchange of information, and they were incredible at providing us opportunities to learn more about the Malaysian healthcare system, about health systems research in general. And they did so by providing us opportunities to attend a lot of these conferences and workshops that they host themselves. So you can see on screen three examples of the many conferences we attended. One was an international conference on the obesity crisis in Southeast Asia that was actually hosted by the United Nations. Another was a narrative storytelling workshop based around knowledge translation that was actually hosted by a researcher from the University of Ottawa. We also attended a conference on food and nutrition. There were a number of other conferences as well. We had workshops on statistics, on how to use SPSS and Stata. We had a workshop on, qualitative research methods. One of the more memorable workshops was a workshop on color, where I learned that I should wear more warm colors to highlight my face. And of course, we sat in on a lot of ministry meetings as well, where we learned about the Malaysian healthcare system, how to galvanize stakeholders to make informed policy decisions. And yeah, those opportunities were all provided to us by IHSR, which we were really thankful for.
So this concludes our presentation. I'd like to give a thank you to McMaster University, McMaster Health Forum, the Queen Elizabeth Scholarship, the Bachelor of Health Sciences Program, as well as the Institute for Health Systems Research in Malaysia.
Thank you very much, everyone. So we'll open it up for questions now. For those of you who are online, if you have a question, please type it into the chat box, and I'll read it off for the recording. And for those of you who are joining us in the room, if you have a question, just let us know. I'll kick things off with a question. Well, obviously, the most important question is, Lucshman, are you now wearing warmer colors?
No, you know what? It's winter, and so I just wear whatever's warm. Not too much paying attention to the colors.
That's fair enough. So a question for all three of you, and I'll give you each an opportunity to respond. I found it interesting the three different projects that you did kind of ran the gamut of being incorporated into a project that's already ongoing and will continue long since you've been gone, so you didn't really contribute other than being involved in the program, to introducing something they didn't have before and setting it up for the first time, to looking at something they are already doing and maybe tweaking it and making revisions to it. So it's kind of, you did the whole spectrum of projects, really. So for each of you, I'm going to ask, what contribution did you as an individual make? Do you feel that what mark did you leave there? And then what did you learn from them that you've taken with you in your, as you've come back to Canada or now in McMaster, Ottawa, or Toronto? So I'll turn it over to Seana first and see.
Great question, James. So the biggest contribution I think I made was for the Deliberative Dialogue assessment tool. And the reason was, before going to Malaysia, we did attend meetings here where we learned about deliberative dialogues and stakeholders. And learning about this, I think, prepared me best to deliver this information and pass it on to the Institute. So as I mentioned before, we engaged in weekly or biweekly meetings with our colleagues. And that was a great learning experience for me because it allowed me to research more on the Health Forum, on health systems research, and then also to frame that wording and that knowledge in a way that the Institute could pick that up and use it. And I think it was very beneficial as well to leave them with these PowerPoints that they had something to use once we left. So it was very inspiring to see our place while we were there for 3 months, but also to know that after we left, they'd use this information that we shared with them for their ongoing projects. Something that I definitely took away while in Malaysia was just the impact of culture. So it has a different religious majority, it has a different language, different customs, and that was something that we all three of us got to adjust to and got to also be embraced in for those 3 months, which was very exciting. And also the food. So every conference and workshop we got to go to was very interesting to see how even food and their holidays shaped how everyone interacted with each other and also conducted research at the Institute.
Great. Thank you. So Elysia, what do you think? Same question.
Yeah, sure. Thank you so much for asking that question, James. I think it's a great question to reflect on. I really think that in addition to what Seana said, we were well prepared when we went to Malaysia to transfer knowledge from the McMaster Health Forum and to apply it to the Malaysian context. And so I think really what we contributed was strengthening their knowledge of knowledge translation and how to conduct certain things like stakeholder dialogues and evidence briefs. But in addition to those things that we conveyed to them from the McMaster Health Forum, I think we also contributed a lot to helping them learn about how we do things. And by that I mean they learned a lot from us in terms of how we conduct presentations. And I remember them being really intrigued by the way that we would prepare a presentation and the software that we use. So we use Google Slides all the time so that we could all see it and all work on it together. And I think that those kind of skills that aid in preparation and aid in delivering content in any context, we really transferred to them and was really useful to them. I think that something that we took away from them and something that being there taught me, I guess, was really to provide cohesiveness to teamwork. I think something that we had to do all the time there was work with large groups of researchers and make sure that everyone was on the same page. And I think that we effectively learned how to do that in Malaysia through working on the evidence brief, working on HCD, and ensuring that communication was done very well in a way that was acceptable to everyone in the Institute. I remember we had a WhatsApp group, and then we also had a lot of in-person meetings and informal in-person meetings to make sure everyone was on the same page, and I think that that is really essential to making a cohesive team project.
Great, thank you. And Lucshman?
Oh, my turn. Yeah, this is a great question. I think in terms of what I think we contributed to IHSR, I think the evidence brief was really important because it was relatively new to them. It seemed they were familiar with the evidence briefs that the McMaster Health Forum had produced, but they seemed like such big documents that they weren't really sure how to go about operationalizing the synthesis of an evidence brief within IHSR. I think that because we were well prepared going in, we were able to give them a timeline of how to make an evidence brief, give them a procedure to do so, and in doing so, how to clearly clarify a problem, assess policy options, and consider the different implementation strategies, which I think was really useful for them. That's what I think was our most useful contribution. What I took away, I think on a personal level, two of the workshops really stood out. The one on qualitative research methods and the statistics one, I still use a lot of that stuff even now. But more on like a group dynamics and team dynamics level, I think I learned the importance of how personal connections within a workplace really, augment the productivity of projects, of teamwork. I think that because I got along with everyone working there, we were able to do really good work, and we were able to communicate better and stay on top of what we were doing. Another, I think, important lesson that I took from Malaysia was the importance of local applicability. I think a lot of the times when we talk to high-level stakeholders, they're really looking for how synthesized research evidence reflects the context, the relevant context that they're in this case, Malaysia. And so that's a lesson that I've sort of taken with me from Malaysia.
Great. Thank you very much. Any questions from anyone in the room? So say your question and I'll repeat it for the recording online. Great. So the question from the room is the biggest challenge for implementing these tools, especially within a different cultural context. So we'll start in reverse order this time. Lucshman, how about you?
Sure. So I think we alluded to a few of them. One was the language and the cultural component. So obviously the way we word stuff or the way we go about explaining how to incorporate tools was different because not everyone had as good a grasp of English, or I should say more correctly, we didn't have a good grasp of the local language. And so that was a significant challenge. And again, the cultural component of receiving feedback That was also a barrier to improving our tool because oftentimes people didn't really want to speak openly, and so that I think was a challenge that we're trying to overcome.
Great. Elysia?
Yeah, just to build off Lucshman's last point, I think a really big challenge to implementing the deliberative dialogue assessment tool was that feedback was really hard to get, and a lot of the times people would respond not honestly because they wanted to be nice and respectful to the people conducting the deliberative dialogue, because that is basically how this work structure works in Malaysia. You're respectful and you're nice to people, and constructive feedback is very hard to get, especially being comfortable with giving constructive feedback in Malaysia. And so administering that tool and assessing the results that we got from that tool was a challenge because of that culture, with that culture surrounding feedback, I should say.
Okay, thank you. And Seana?
Looking back on the 3 projects that we were working on, the biggest challenge that comes to mind is making sure that the bilateral exchange of information is even. So as we were giving presentations, it was to also make sure that we are taking things away from the Institute as well, and that was something that was brought up at our meetings, was that even though we have information to share, there's also so much that IHSR knows that McMaster Health Forum may not be having in practice. And so understanding that we are there to learn from them as well as us sharing our information here at the Health Forum.
Thank you. Any other questions from somebody in the room? I'll let them think about it while I'll bring another question forward. So we've talked about the work that you've done, so let's talk about where you were. So somewhere in the world, it's very unique. Malaysia, I'm assuming, is quite different from Canada. So asking each of you, where's one place that you went, one thing that you experienced, something that was very uniquely Malaysian that you look back on fondly?
Sure. So near the end of our trip, actually, our boss at the Institute for Health Systems Research took us to this Malaysian cultural show. And so alongside the show with cultural dancing and music and singing and songs, we had cultural food. And so something that we learned very early on in Malaysia was that they love their food. So at every conference, every workshop, anything that would require food, there was a huge delivery that came in. And so we always had, for the most part, breakfast or lunch covered. And so it was really interesting to see the dance that went on, and also to interact with our colleagues at the Institute on more of a personal level. So instead of talking about work, it was very cool to see their lifestyles or their spouses and to watch something very uniquely Malaysian and to see how proud they were of that.
Thank you. Elysia?
Yeah, I think Malaysia has a lot of amazing cultural aspects to it. Something that I really took away from Malaysia, and it made me realize the difference how we do things in North America, was that in North America we're so time focused and everyone's always on an agenda and a schedule. In Malaysia, I think it was more of a lax work environment where people would spend time talking about things and really focus on the relationships that they had with each other, and also they were so focused on timing. And I think that really provided a more relaxed work environment, but also like a very conducive work environment in specific ways. So that's definitely something that was uniquely Malaysian and I found very pleasant to work in.
Great. And Lucshman?
Yeah, so I think one place that we went to was a place in Malaysia called Penang, which is just an island off the coast. And while we were there, it was really just sort of an embodiment of everything we had seen in Malaysia up until that point. Just like a whole, it's just like a diverse mosaic of cultures just coexisting and expressing their culture within the built environment, which is really cool to see. And just the food was incredible, the music was incredible, the people were incredibly kind, and that was sort of like a real, that was sort of like a lot of the things that I observed in Malaysia were sort of embodied in that place, and so that was a really incredible experience.
Great, thank you. Any other questions from anyone in the room? Anyone online using the chat box? Everybody's just looking at me blankly now. So I think this is a good opportunity for us to kind of draw this to a close. So I want to thank Seana, Elysia, and Lucshman for joining us today from 3 different locations. It worked out quite well, I think. And thank you very much for the great work that you did in Malaysia. They have since emailed and spoken highly of all 3 of you and the work that you've done. So I think you've definitely made an impact there. And it looks promising that they'll accept more students in the future, which is always a good thing for us here at the forum in the scholarship program. So I'm just going to advance quickly to the last slide here, which is our thank you slide, and just to point out a couple of links there for informational purposes. The first one is a description of our scholarship program here at the Health Forum, so feel free to visit that link if you want more information about it. All of our scholars will be doing webinars, so we have currently a webinar schedule, so please visit that second link for more webinars that will be coming to you this term up from now until December the 13th. And the third link, all of our scholars also produce a blog post for us, which is more of somewhat on the more personal side, their experiences when they were traveling and what they went through and the insights that they have. So that third link is to our blog page, so please visit it and read the blogs from our scholars as they're posted. And once again, thank you for those of you who joined us here today, and thank you again to Seana, Elysia, and Lucshman for joining us, and hopefully we'll see everybody again really soon.